G'day, I'm Bruce Campbell, stroke neurologist from Melbourne, Australia. It's my great pleasure to be interviewing Dr. Marc Ribo, interventional neurologist from Hospital Valdehebron in Barcelona, Catalonia. Marc is co-principal investigator of the Racecat trial, which has been investigating the potential benefits of paramedic triage of patients with suspected large vessel occlusion direct to an endovascular capable hospital. Marc, congratulations on completing Racecat. I, for one, have been eagerly awaiting your results. And can you tell us the aim of the study and the key elements of the methodology?
Sure. Thanks, Bruce, for the introduction. So already 4 years ago, we wanted to answer the important question about what is the best workflow for patients that are suspected to have a large vessel occlusion stroke far away from a comprehensive stroke center. And since we have two major treatments that both of them work, thrombolysis, IV thrombolysis, or thrombectomy, it is very reasonable to ask this question. Should we prioritize IV TPA and take these patients to the closest center in order to get immediately potentially TPA and therefore a secondary transfer for thrombectomy? Or should we just prioritize endovascular treatment, taking the risk of delaying IV TPA, however, advancing the groin puncture and the potential benefits of thrombectomy? So we decided to put together the Racecat trial, and it took us 3.5 years to complete 1,400 patients included. And now we are ready to present the results.
So what did you find?
So we were initially kind of surprised because after the second interim analysis, the Data Safety Monitoring Board suggested us to halt the trial recruitment because of we achieved a futility boundary. Now that we have completed the follow-up of all patients, we have found that basically in the whole population, there is really no benefit of transferring the patients directly to the comprehensive stroke center as compared to transfer the patients to the local stroke center. You will see in our presentations that the treatment effect for the primary outcome, which is disability, the shift analysis on the ranking score at 3 months, is completely flat for ischemic stroke patients. So we were initially surprised by the data, but after taking a close analysis, we start to understand why this is we have these findings. So first of all, I want to emphasize, and I will have to emphasize it as many times as possible, that the trial was performed in a setting in our network which is highly coordinated. One of the major findings that we found is that, for example, we achieved rates of endovascular treatment of acute ischemic stroke patients of 50% when transferred directly to the comprehensive stroke centers, and only of 40% when the patients were transferred initially to the local stroke center. So there was only a 10% decrease in the number of thrombectomies, and the delay that we observed was also much shorter than we expected, only 50 minutes later. So going through the endovascular to the local stroke center meant only 10% less of chances for the endovascular treatment in 50 minutes later. On the other hand, it meant an additional 15% chances of getting IV TPA thrombolysis. So I think this is one of the major conclusions of our trial. If local stroke centers perform highly well and in a very good coordination with the comprehensive stroke centers, there is no reason to bypass those patients for the local stroke center.
That is fascinating, Marc. So did you get a door in, door out time for the non-comprehensive centers?
Exactly. So the what we call the modified door in door out, which is the time by the local stroke center is ready to transfer the patient and calls EMS, is 45 minutes, including all the assessment and IVT PA treatment if needed. The total door in door out is roughly higher than 60 minutes, which is only, I think, a very good performance. On the other hand, for those patients transferred from a local stroke centers that received thrombectomy, we observed that the door to groin time was only 33 minutes. So that meant that there was a very good transmission of the information. The receiving team had all the information necessary, and within 30 minutes, they were ready to do the groin puncture.
That's great. So did you get an idea of the diagnostic performance of the RACE tool? How many patients that were bypassed actually ended up getting thrombectomy?
Yes. So I think that another conclusion of this trial is that we confirmed, let's say, that the RACE is a great tool to identify stroke patients. So just as a reminder, this screening, the initial screening, was performed by paramedics on the scene without anything else than the training to do the RACE scale. So from all included patients, finally 50% had a confirmed large vessel occlusion, and 23% had an ICH. Moreover, from all ischemic stroke patients, up to 2/3 had a confirmed large vessel occlusion. So this data confirm that the RACE score is a great tool to identify patients with a suspected LVO.
Well, congratulations again, Marc. And what will you do in Catalonia now?
Okay, so I also want to mention that these are very fresh data. We just closed the database 3 days ago. We did the analysis on the very last minute, and we're still pending of all secondary analysis, or most of secondary analysis, including the impact of the distance. We believe that there might be some differences in outcome according to the initial distance to the comprehensive stroke center that we still need to confirm and will present in further occasions. And once we'll have all sub-analysis performed, we certainly will work with EMS to develop new protocols optimized to improve the outcome of our patients.
Thank you again very much, Dr. Marc Ribo and the Racecat trial.
Thank you for your interest, and looking forward for the discussion at the meeting.